National Rehabilitation Institute, Chandigarh. So as we gather here, so we do under the powerful and visionary theme, Azadi from Deafness 2025. So we are gathered here to celebrate the World Disability Day, and as we deal with the disability of hearing and speech, so we will be celebrating this day today. This gathering is just not an event, it is a continuation of a pledge we made previously. As many of us know that we organized this event last year with great success, and keeping this tradition alive is crucial for raising awareness about deafness and fostering an inclusive society. As the head of the department, I want to take a moment to reflect on the strides we have made over the last year, and our role extends far beyond the operation theatre. At PGI MER, we are dedicated to holistic approach to hearing health that encompasses three clinical pillars, that is early diagnosis, precise treatment, and comprehensive rehabilitation. In the realm of diagnosis, we are constantly pushing for earlier detection of hearing loss, knowing that time is of essence in preserving the communication skills. Regarding treatment, our department continues to adopt state-of-the-art surgical skills, surgical precision, and medical interventions to restore the function whenever possible. However, surgery is often just the beginning in this journey of deafness. This brings me to a vital part of our ecosystem that I am particularly looking forward to acknowledging today, that is the speech and hearing unit in our department. The speech and hearing unit was established in our Department of Otolaryngology and Ethnic Surgery in the year 1979, and that time it was headed by Dr. M. Raghunathan. He was in charge of that unit, and his wife, Dr. Meena Raghunathan, was other faculty member with him. And today we have five faculty members, 7 junior speech therapists, and we have 40 BA SLP students and 9 masters in audiology students in this unit. So it is a big unit today, and Professor Sanjay Manjal is in charge of that unit. The contribution of our speech and hearing unit is the bridge between a successful surgery and a successful life. Their tireless work in therapy, audiological assessment, and support turns hearing into understanding and communicating. So we are looking forward to their continued excellence, and I am happy to see that later in day today, we will be presenting appreciation awards to the PGI alumni of Speech and Hearing Unit. We have an engaging schedule ahead in this gathering today, including talks by my faculty colleagues, Professor Ramandivir, Professor Roshan Verma, who are part of the cochlear implant program team in my department. And we have invited faculty, Professor J.K. Mahajan. He is head of the Department of Pediatric Surgery in PGI MER. He will also be delivering one talk. And Dr. Aninda Dhutimanik. He is Senior Manager Clinical and Research, Southeast Asia. He will be reaching soon from Mumbai. So let us use this time to share the knowledge, celebrate our milestones, and recommit ourselves to the goal of Azadi from Deafness. Thank you all, and I welcome you all again. Jai Hind. So I will be introducing briefly about World Disability Day, why it is celebrated and what is its significance, and what we have done over the last 1 year to reach this day today. So World Disability Day is celebrated on 3rd of December every year, and it has been initiated by the United Nations in 1992, and since that this has been celebrated as International Day of the Persons with Disabilities, and it is an international observance promoted by the United Nations. So the theme of this year, every year it has a different theme, and this year the theme is fostering disability inclusive societies for advancing social progress. The purpose is to promote understanding of disability issues, advocate for rights and well-being of the people with disabilities, and highlight their social, economic and political gains from their full participation in the society. The goal of this year's theme is to build more accessible, resilient and inclusive societies by breaking down physical, digital and social barriers. So there are 21 different types of disabilities which are covered in the PWD Act. This is Right for Persons with Disabilities Act, which has been established by the Government of India in 2016, and it covers 21 different types of disabilities including speech and hearing, mental illness and many other locomotor disabilities, low vision, blindness and hematological disorders like hemophilia, sickle cell disease, etc. And disabled people have special provisions, like there is provision of 4% reservation in government jobs for disabled people and 5% reservation in higher education institutes. So deafness, coming to the deafness, it is a silent struggle. And if we see the global burden of hearing loss, 466 million people all over the world are experiencing hearing loss. 900 million people will have some hearing loss by year 2050. 60% of the childhood hearing loss is resulting from some preventable causes which can be treated, and 1.1 billion number of people between the age of 12 and 35 years are at risk of hearing loss due to noise exposure. And it has a huge economic burden. $750 billion is the economic burden for hearing loss. India's footprint on the global hearing loss landscape is that in India, 1 in every 6, 1 to 6 per 1,000 live births, they are with congenital hearing loss, as reported by Ramaiah et al. In the Indian Journal of Otolaryngology 2021. And there are 26 million people in India living with some form of hearing impairment. As the newborn hearing screening is not still universally implemented all over India, many children miss the critical early window for cochlear implantation. As a result, despite the availability of cochlear implants in India, delayed diagnosis, socio-economic disparities, poor post-implant rehabilitation access, genetic heterogeneity often lead to the suboptimal outcomes, as reported by WHO CERO 2022 data. So in India, we have a national program for prevention and control of deafness, which is known as NPPCD, and it has the motto of 3 + 3 + 3, which means that by the age of 3 months, every infant should be diagnosed with hearing loss, whoever we suspect as having hearing loss. By next 3 months, that is at the age of 6 months, hearing aid should be fitted, and by the age of 9 months, cochlear implantation should be done. So this is the patient statistics for hearing loss and rehabilitation in our department from 2024 to 25. And here we see that total patients who presented to the speech and hearing unit were 23,000, and patients receiving speech services were 6,300. Total hearing assessments done were 14,000, and around 4,500 people presented with speech and language disorders of various types. 1,350 audio verbal therapy sessions were given to the deaf patients, and hearing aid trials were given to 900 patients, and they were advised hearing aids. The neonatal hearing loss screening program we have running in collaboration with the Department of Pediatrics, and 4,800 neonates were screened for deafness. Out of these, cochlear implants were done in 58 patients over 1 year, and 2 bone bridge implants were performed, and 2 auditory brainstem implants were done. So we have a way forward to CI program at our institute. So the total, this is the data of total implants performed. 41 were children, 12 were adults, 5 adolescents, and government funding was available for 36 patients. 22 patients had self-funding for cochlear implantation. our vision is to establish an advanced cochlear implant center in PGI MER and to enhance life through dual hearing solutions. For that, we are planning to do bilateral cochlear implantation, and simultaneous bilateral cochlear implantation has lot of benefits as compared to the sequential implantation, and it has benefits like enhanced binaural benefits. There is immediate binaural hearing after implantation. Rehabilitation is simple and synchronized. It will have low overall cost. Surgery will be single visit, and so our vision is aiming to enable individuals with profound hearing loss to achieve their full potential through timely and effective bilateral cochlear implantation, fostering better communication, social integration, and quality of life. So this can be done through early detection and intervention. As I said earlier, that by the age of 9 months, every deaf child should be implanted with cochlear implant, and this has been established by FDA also. There should be accessibility and affordability for cochlear implantation to every deaf patient. We should have policy advocacy, and there are various government schemes which are funding for cochlear implantation, like ADIM scheme, RBSK Yojana, IESI scheme, PM and Chief Minister relief funds. They have comprehensive health insurance schemes for deaf patients. Assistance from Member of Parliament and Legislative Assembly can also be sought, and assistance from Red Cross Society, from Armed Forces Medical Care, and from various NGOs. The comprehensive care should be there for better outcomes in cochlear implants, which include multidisciplinary approach, including audiology, speech therapists, psychologists, pediatric physicians, pediatricians, neurologists. Regular follow-up and required programming and adjustments of these devices has to be done, and we can have personalized rehabilitation programs. Emphasis on patient and family education related to cochlear implant is very important, and this is being done regularly for counseling of the families and parents for regarding early implantation, regarding the sources of funding for cochlear implants, and various educational resources and support groups related to cochlear implantation. Public awareness is being done through campaigns which are being carried out in community camps. We do hearing screening camps in the community regularly, and research and innovation is being done in the department in this field. Monitoring and evaluation is being done by implementing systems to track the program outcomes, data-driven adjustments and improvements, and feedback mechanisms. The impact goals of this program are enhanced auditory experience and communication skills in the implanted patients, improved social and academic outcomes of the deaf patients, and overall quality of life enhancement of these patients. Professional training and development is required of the professionals who are dealing with cochlear implant program. Like we have training healthcare professionals in the latest technologies, in the surgical technologies, in the rehabilitation technologies, by workshops, seminars, and certification programs. So we have introduced new program for cochlear implantation. This is the SmartNav system, which can detect exact location of the implant in the cochlea immediately inside the operation theatre, and it can save time for implant mapping and for MRT after implantation. So it gives us satisfaction whether the implant is in correct position in the cochlea, whether it has good impedance, all the electrodes are in position. So it can save up to 45 minutes to 1 hour of operating time and anesthesia time. So simultaneous bilateral cochlear implantation, as I stressed earlier, is being done, and around 4 patients have received simultaneous bilateral cochlear implantation, and these are very small kids, 2 years of age, and we can see their outcome. This child has only 2 months after CI surgery, and see the progress. Previously it was a totally deaf child.
No. अनुपम की आईज कौन सी है? आईज, नोज, हैंड,
another child who has been implanted recently, 3 weeks back, and these are the bilateral cochlear implants in situ. And these are various child recipients who have received cochlear implantation. And these are adult recipients who have been implanted and they had hearing loss due to various reasons. And these are the children who are doing very well after cochlear implantation. So a totally deaf child after 3 months of surgery can speak and can hear. So results are very encouraging in totally deaf patients who have profound hearing loss.
13, 14, 16, 20.
So post-cochlear implantation rehabilitation has a very large role in the successful outcome of the cochlear implantation, and which is being done by our rehabilitationists and speech therapists and audiologists. So it is a long journey, cochlear implantation, but see the results are so encouraging that we are giving the gift of sound and a good life to the deaf patients. That's all. Thank you very much.
Thank you, ma'am, for your talk. Now I would like to call our chief guest, Professor Sanjay Jain, Lead Research PGI, to deliver a few words. Thank you.
Thank you and good afternoon, everybody. Dear friends, it's always a matter of great pleasure for me to be associated with programs which are thematic and aimed at alleviating human suffering and reducing human disease. I must say that disability of any kind, whether physical, mental, financial, or of any kind, actually adds to the human misery. The best example to alleviate this type of human suffering, I think it comes from the Department of ENT, and I would say and I would congratulate the leadership of Professor Dhiman, especially the speech and hearing unit, which is led by Dr. Sanjay Gunjal, for doing such a wonderful job. I think all of you would agree that we as medical professionals have one thing in common, that our aim is same. It's basically to reduce pain and bring back joy to life. I would say that hearing disability actually is one of the most important disability which remains unrecognized. Only possibly a complete deafness is what is known, but what is not known and possibly ignored, in which the person keeps on keep on suffering, and that's because of the hearing disability. I would say only a person who is either completely or partially deaf would understand my feeling, because for a person who is deaf, the sound plus the communication is fractured and the sound comes few seconds. Actually, the life starts few seconds after a normal person. And what a better thing you can do if you can bring back smile on the face of such person. Let me share you a personal anecdote on that. We as doctors, we have issue always at home, that who will run the home, whether it's your spouse or whether it's the maids and the helpers. So like as I said, that my house is run by my maid. In fact, my wife on her cell phone, her name is Pooja, has put as Pooja VIP and my name is Sanjay Jain. So, you know, but she's with us for the last about 20-25 years, and she looks after her house and we look after her household by financial means. So over a period of time, what I realized, that was about 5 years ago, that she was not actually following our commands or our advices, how the kids to be brought, where what is to be cooked, etc., etc. So suddenly, naturally, there was a chaos at home, and my wife, as usual, would credit that you are spending all the time in the hospital and the house is going haywire. So do something about it. Then suddenly I realized, there is a problem either with our communication. And I thought that there is a problem with the hearing, and I brought her to Dr. Sanjay Jain. At that time, it was 5-6 years ago. And very correctly, immediately, the correct steps were taken, a hearing aid was provided. And you would not believe that within a period of about a month or so, the things changed and it came back to normal. So my household actually is running properly. Part of it goes to the team of speech and hearing. So I'm not trying to say that it can make a difference to that individual. Please ask that individual what he suffers from, he or she suffers from, and what or he or she goes from once he gets all this. So the Department of ENT here, as Dr. Jayanti was mentioning, is not only treating the disease, but equally important is to produce trained professionals. Because one of the aims of PGI is to produce enough medical personnel who can deal with all these conditions. And as you have seen, that it ranges from preventive, minor form of treatment like otitis media to the most complex and the most advanced, that is cochlear implants. And as I said, that if the department is doing it, they need congratulations. But equally important, I would say, is the role of other government and non-government organizations. Please remember that nothing moves without money, logistic supports, finances, moral support, and disseminating the knowledge. And I believe that I would also like to thank all the NGOs who are participating in the same. Please remember, as we are celebrating World Disability Day, that I'm just focusing on one of the 21 components of disability. So I would say that finally, if we are able to bring a smile on the face of a patient, that's the best reward you can get. And on this note, I would say that I wish you all the best in all your endeavors, and God bless. Thank you.
Moving forward, we are honored to welcome our guest of honor, that is Shri A.K. Datta, Director of Bharat Vikas Parishad, to share his thoughts. Welcome you, sir.
नमस्कार, प्रोफेसर संजय जैन जी, प्रोफेसर जयंती बख्शी जी, हमारे विपिन कौशल जी और सभागार में उपस्थित सभी भाइयों, आज हम पूरे विश्व में वर्ल्ड डिसेबिलिटी डे मना रहे हैं, क्योंकि मैं एक एनजीओ से बिलोंग करता हूँ और एनजीओ इसमें बहुत बढ़ चढ़ के हिस्सा लेते हैं। जिस एनजीओ से मैं बिलोंग करता हूँ उसका नाम है भारत विकास परिषद। पूरे देश में हमारी जितनी भी शाखाएं हैं, ब्रांचेस हैं, वो जितने भी हमारे डेफनेस हैं, जिसको हमने लिखा आज़ादी फ्रॉम डेफनेस, उनको कैसे हम हेयरिंग एड लगाकर फ्री ऑफ कॉस्ट जो है हम उसकी ज़िंदगी के अंदर कुछ बदलाव कर ला सकते हैं, तो उसमें हम हमेशा लगे रहें। लेकिन ये केवल एनजीओ के प्रयास से नहीं होता, जब तक इसमें मेडिकल प्रोफेशन के लोग साथ ना जुड़ें तो ये काम अधूरा है। तो मैं पीजीआई को और पीजीआई के पूरे इंस्टीट्यूट को इस चीज़ की बधाई देता हूँ कि इन्होंने हर साल इतने लोगों को ट्रेंड करके इस क्षेत्र में भेजते हैं, और पूरे विश्व के अंदर, क्या भारत में, पूरे विश्व में जाकर ये लोग ऐसे लोगों को जो कि शायद सुनने में एक बड़ी तकलीफ महसूस होती है उनको, लेकिन उनको हम इजीनेस में दे सकते हैं ताकि वो अपनी लाइफ के अंदर किसी में बोझ न बनकर अपने आप में सेल्फ डिपेंडेंट हो जाए। एक बहुत बड़ा काम है और भारत सरकार भी इसमें बहुत बड़ा रोल अदा करती है, काफ़ी फंड इसमें लगाए जाते हैं। और हमारा जो उद्देश्य है कि एक आम आदमी, एक आम जन जो बाय बर्थ जो है उसको डिसेबिलिटी हो सकती है, एक्सीडेंटल हो सकती है, या फिर एजिंग के हिसाब से, लेकिन मेरे को समझ आता है कि एजिंग के हिसाब से शायद डिसेबिलिटी बहुत ज़्यादा है, और उनको जिस समय उनकी एज काफ़ी हो जाती है तो एक ऐसी लाइफ में होता है जो जिसको होती है उसको पता है उसको क्या सफरिंग है, तो उसको हम अगर अब थोड़ा सा अपना ट्रीटमेंट दे के या कोई इंस्ट्रूमेंट लगा के उसकी लाइफ को इजी कर देते हैं तो ये बहुत बड़ी बात है। तो मैं अपनी तरफ से, अपने भारत विकास के लिए, सारे एनजीओ की तरफ से आप सबको बहुत बहुत बधाई देता हूँ कि आप सब लोग इस काम में लगे हुए हैं, और आपको भगवान इतनी शक्ति दे कि आप भारत में ही नहीं पूरे विश्व में से इस तरह की जो डिसेबिलिटी है इसको दूर करने में अपनी सहायता प्रदान कर रहे हैं। ये बहुत बड़ी बात है। धन्यवाद।
Thank you so much, sir. We are also joined by Professor Vipin Kaushal, Medical Superintendent and Chairperson of the Disability Board at PGI Chandigarh. Sir, your work in administration and disability welfare is inspiring. Now I will continue with felicitating our chief guest and guest of honors. I would request Professor Sanjay Jain sir to come forward to the stage. Jayanti ma'am to please honor sir with the certificate and the memento. I invite Shri A.K. Datta sir to come forward to the stage, Jayanti ma'am and Satyavati ma'am to felicitate with memento and certificate. I welcome and invite Professor Vipin Kaushal sir on the stage for the felicitation and welcome. Ma'am, please felicitate sir with certificate and memento. I invite Mr. Ashwini Dhiman from ASTEP Foundation NGO for their felicitation. Please join on the stage. Ma'am, please. I would request Sanjay Jain sir to come on the stage to felicitate. He has an NGO called ASTEP Foundation. Thank you, sir. Thank you, ma'am. I would request to every guest and guest honor to be seated in the audience. Now we will be moving to the academic talks. The first talk is scheduled for Dr. Roshan Verma sir, I would request to please come on the stage for their talk. The chair for this session is Professor Sandeep Bansal sir and Dr. Dharamveer sir. Please join on the stage.
Thank you very much. And so we are celebrating Azadi from deafness, Azadi from disability. So I have chosen the topic of similar topic, that is Azadi from deafness. And why is it important? Because blindness cuts out from the things. We can't see with blindness, but we can't hear with deafness. We are cut off from our surroundings. And once we are cut off from our surroundings, we are socially isolated and will not become a productive member of the society anymore. So deafness, we have heard a lot of terms. Deafness, it's deafness, hearing impairment, and hearing disability. What is these things? Deafness is complete loss or partial loss of hearing from one or both the ears. Hearing difficulty is difficulty in hearing in day-to-day conversations, and this, the criteria given for hearing disability is that is a hearing loss in the better ear of more than 40 decibels in adults and more than 30 decibels in children. But why are we so bothered? Why do we think that we need Azadi from deafness? Because of its magnitude. As Madam has said, that the global burden estimate is around 1.5 billion people are suffering from deafness at present. And in India, the burden is around 75 million adults, and the estimated prevalence is roughly around 6.3%, and roughly around 291 persons out of every lakh population is suffering from some form of deafness. As far as hearing loss in neonates are concerned, the hearing impairment in neonates amounts to around 2.2 to 4.1 per thousand population of babies screened, and this depends on the risk and high risk and low risk infants. And without risk factors, the risk is around 0.6 to 4.7%, and risk in with risk born babies, the incidence increases to 7 to 49.8%. And these risks may include NICU stay, prematurity, low birth weight, neonatal comorbidities, meningitis, and low abdominal scores during birth, maternal risk factors, birth asphyxia, congenital history of deafness, and ototoxic drugs and hyperbilirubinemia. But we also see hearing loss in children, and the prevalence is estimated to be more as compared to neonates. The incidence is roughly around 6.9 to 25.1% of the population, and around 6 to every 1,000 school-going children have some form of hearing disability. And common causes include very simple causes like wax, otomycosis, foreign body, and treatable causes like congenital otitis media with effusion and otorrhea, and of course congenital deafness. Somebody was speaking about hearing loss in adults, in elderly, and the incidence is as common as 1 to 3. 1 in every 3 individuals suffers from hearing loss in the age group of 65 to 75 years, and above 75, 1 in 2 individuals suffer from some form of hearing loss. And common causes in such elderly groups are presbycusis, noise-induced hearing loss, venous disease, sudden sensory loss, and ototoxicity. What happens when you have hearing loss and children? There are signs that to detect that these children do not hear. They may not be able to respond to sounds. There may be lack of attention. There may be cognitive difficulties, and their speech may be unclear. So the consequence of hearing disability in children are much more worse as compared to adults. They may have speech and language communication issues. They may have cognition issues. They may be socially and mentally isolated, and they do not go back to their normal peers in schools. What happens in adults? They have communication issues, they have difficulty following sounds, they have difficulty hearing in noisy environment, they have problems like tinnitus, and it is seen that dementia is more common in the people who have hearing loss. They have more incidence of hypertension, they have more incidence of tinnitus, depression, because they are not able to hear. So coming to causes of hearing loss, 50% are environmental, which are mainly neonates, there is meningitis, cytomegalovirus. These two are very important cause of hearing loss in neonates, and 50% are genetic, which can be due to Alport syndrome, Norris syndrome, Usher syndrome, and 70% may be non-syndromic. In children, the most common cause of hearing loss are wax, foreign objects, otitis media confusion, suppurative otitis media, or it may be genetically, it may be infections like meningitis, mumps, and measles, exposure to loud sounds, head trauma, and toxic medications. In elderly, the common causes are as simple as cerebral impaction and otitis externa. In middle year, they may have otitis media, vascular chain disruption, or cholestoma. And in inner ear, they may have presbycusis, noise-induced hearing loss, venous disease, and acoustic aroma. Now coming to Azadi from deafness, how do we achieve? We have known these are the difference, these are the causes, what is its magnitude. So we achieve Azadi by prevention, by early detection, recognition, treatment, and rehabilitation, and by national programs. So coming to prevention, as previously told, 60% of deafness in neonates are preventable, and 40% we may not be able to prevent. And how do we prevent? We prevent by prevention of consanguineous marriages, by preventing birth-related complications, by vaccination of mothers against rubella and cytomegalovirus, preventing premature birth, avoiding use of toxic medication by the mother during pregnancy, and drug or alcohol abuse by the mother during pregnancy. In children, it is more common cause of deafness than in neonates, and very simple causes like we should monitor the school performance, treat ear pain and ear infection, and one of the most common causes is the noise-induced hearing loss, now being due to personal hearing devices like mobiles, and never slap the child because he may have perforation and go on to develop hearing loss. How do we prevent deafness in elderly? So we manage comorbid condition because presbycusis occurs early in elderly persons, treat coexisting medical conditions, treat ear infections. Most of the elderly may have hearing loss just because of wax, and a removal of wax may improve their hearing loss, avoiding exposure to loud sounds, and avoiding toxic medications. Now, preventing this is one of the major causes of hearing loss, so I've included in this slide. How do we prevent hearing loss? We walk away from the noise, stand away from speakers, reduce the volume to halfway, limit the exposure of noise to less than 60 minutes or 1 hour, turn the volume down, and wear ear protection devices. So how do we detect as early as possible? Remember the rule of 1:1, 3, and 6. At age 1 month, all the infants should have screening done. At 3 months, those who have been screened, they should have been able to diagnose that these children have hearing loss. And at 6 months, intervention should be done either with hearing aids or cochlear implantation. So Universal Hearings program is being implemented now, and in this, all the babies who are born are screened, irrespective of whether high risk or low risk infants, and they are initially screened with OE and automated AVR, and once they pass the screening test, it is excluded, and if they fail, then they are again screened at the age of 6 months, and by the age of 6 months, once they pass, they are excluded, and if they fail, their intervention is done either in the form of hearing aid or implantation. School health screening is a very important to diagnose hearing loss in children because there is increased prevalence as compared to neonates. 50% of the children with hearing loss at the age 9, they would have normal universal screening, they would have bypass the hearing screening, And universal seeing may not be able to detect 10 to 20% of the hearing losses. And at what time do we do school health hearing screening program? At their entry to the school, at the kindergarten stage, and at school every yearly. And the components may include questionnaire given to teachers to detect children who are having hearing loss, a ear examination including otoscopy or Piotrn audiometry and technometry. Intervention, effective screening intervention for effective intervention. Hearing screening is very important, which should start from newborn to school-age children to people exposed to noise and those exposed to ototoxic drug and in older adults. Rehabilitation techniques may include hearing aids, cochlear implant, and auditory training. Early intervention is very, very important for successful outcome. The intervention in the neonates may be as early as 6 months. The child may be given hearing aids. First devices with the child can be fit with hearing aids, and cochlear implantation is recommended only in severe or profound hearing loss in which the child cannot access all the sounds of speech. And this is the results you achieve with cochlear implant when you intervene early. So early intervention helps them to achieve the outcome. They are able to go to school, they are able to mingle with the peers, and they achieve the desired outcome, the language, and they are able to acquire the language skills. So either with hearing aid or with cochlear implants, the intervention should be done as early as possible in children. Intervention in teens may include avoiding noise exposure and following the 60-60 rule. This is that when the children listen to music, they should be the volume should be reduced to 60% of the maximum value, and the timing should be limited to less than 1 hour. Medications or surgery can be done for treating conductive hearing losses, and we should advise hearing aid technologies like hearing aid and cochlear implant, and also use assisting listening devices like FM in the schools. Intervention in elderly can be in the form of removal of wax, surgery for middle ear conditions like capnoplasty and mastoid surgeries, hearing aids, cochlear implantation, use of assistive listening device, and speech reading and auditory training, which can enhance the listening ability of elderly persons. A word about National Policy for Prevention and Control of Deafness, which goes a long way in preventing the deafness program, and its component includes manpower training, capacity building, service provision, and awareness generation. So we can achieve freedom from hearing disability by raising the awareness and by early intervention. Thank you.
Moving on to the next session, I would like to invite Professor J.K. Mahajan, HOD Department of Pediatric Surgery, PGI Chandigarh, to deliver his talk on nuclear clip and palate. For this session, may I request Chairpersons Dr. Anuradha Sharma, Dr. Maryada Sharma, and Dr. Nurain Alam to kindly take their seats on the dais.
I thank the organizers for including me in this program on very important World Disability Day. I will not be talking directly about hearing or speech, but an important cause of derangement in speech and hearing, that is cleft lip and palate deformities. It is an important cause in the sense that cleft lip and palate incidence is around 1 in 700 to 800 live births. So we have significant amount of population of patients who suffer from this defect. So in relevance to today's day, I will just talk about the outcome of cleft palate patients which we handled in PGI. So one of the main aims of cleft palate repair is to do watertight closure to create a partition between nasal cavity and oral cavity. At the same time, to repair musculature of soft palate, which is important for speech development. When should it exactly be done? Timing is controversial, but definitely it should be done before development of speech, that is 1.5 to 2 years. And about 25% of patients will have maxillofacial development defect also. First, I will recapitulate what options are available in literature, then talk about what modifications we have done and what are our results with those modifications. So in literature, earliest repair available is one-leg palatoplasty. That is, you simply freshen the edges of the defect of palate on either side and suture in the midline. Later on, modifications were done to repair the levator palatine muscle also, which is important for speech development. The next repair was body killer repair, or which is popularly known as BY pushback palatoplasty also. In this, the flap designs are similar to the previous repair, but there is posterior lengthening of palate, that it is sutured and pushed back posteriorly so that it touches the pharyngeal wall and there is no velopharyngeal incompetence. Then next repair was two flap palatoplasty, that is used for relatively narrow clefts, and the relaxing incisions are given on the other side. It has minimal effect on maxillofacial growth. Then next development in the series of palatoplasty was Furlow's double opposing Z-plasty. That is, Z flaps are created and then muscles are sutured in the midline, and there was success reported with speech outcome as well as maxillofacial skeletal growth. Vomer flaps, that is flaps raised from the nasal septum on either side, are important in the sense that they will lead to lower fistula rate, less maxillary growth retardation, and long-term effects on facial growth. Sometimes it's not possible to close the palate with the conventional repair, then one has to do two-stage repairs. That posterior palate is closed initially, that is around 4 to 6 months of age, and anterior palate, that is hard palate, is closed later on. Some cases 12 to 15 years, then some workers reduced the age to 15 to 18 months, and few people did it around 5 to 6 years of age. But whatever is done, speech development according to them was not affected to a great degree. So many times the tissue in the palate is not enough, and one has to use pharyngeal flaps, that raise flaps from the posterior pharyngeal wall and suture them to achieve tension-free closure. Intravelar veloplasty was an advancement that simply, in simplest terms, means that the palatal muscles which are attached to the cleft palate on either side, they are detached from the cleft palate and sutured in the center to achieve veloplasty, which will help in good speech development.
So various modifications and various workers used it over a period of time, and velopharyngeal incompetence, which probably the ENT colleagues will be aware, that decreased from 10% to 4%, 5%. That is, in one sense, means better speech. So whatever method is repair is used, it is well known that normal speech development in older children is more difficult than in younger children. So with this background, we modified the technique which we used for palatoplasty, in the sense that excessive dissection was avoided, because otherwise it leads to fibrosis and adverse maxillofacial growth, as well as speech impairment. Intravillar veloplasty was done in all the cases. So intravillar veloplasty, we separated muscles from the posterior edge of the palatine plate and sutured the muscles in midline. The muscles were not dissected from the oral mucosa, and the oral mucosa and muscles were sutured together as one unit. So one can see that there is a palatal defect. Then mucoperiosteal flaps are raised from anterior hard palate, and this is the arrow points to the palatine edge where the velar muscles are attached. So muscles are detached from this, and muscles are detached from nasal mucosa also, but not from oral mucosa. So this is dissection completed on other side also. Smaller arrows point to the palatine vessels. Palatine vessels, the lateral medial edge of palatine canal is freshened and it's cut so that when flaps are sutured medially, the palatine vessels are not under tension. Then once dissection is completed, then suturing begins. Both the arrows point towards the palatal muscle being sutured in the midline. So this is completed repair. The lateral defect is packed and it ultimately closes by epithelialization. Hamulus, whether it should be broken or not, that is one of the unanswered questions, but we did not break hamulus in any of our patients. So over a period of 15 years, 196 patients of cleft lip and palate were operated, 161 were the palate patients. Out of those, 65 had cleft lip also, and 96 patients had only isolated cleft palate. Majority of our patients were operated after 2 years of age, although we wanted to operate them before 2 years of age. And when sex distribution was seen, it was seen that females had combination of defects, that lip as well as palate, whereas male has combination of defects, whereas isolated defect was more common in female. When we analyzed these patients for speech, clear speech was seen in more than 50%, that is 56% of patients. 38% of patients had speech not clear but understandable. So together, this category A and B, you can say socially acceptable speech. And only 6% of patients had not understandable speech. Similarly, younger patients, they did better when clear speech was concerned as compared to the older patients. Speech outcome was also more the severity of defect, more severe the speech quality, more severely affected the speech quality was. So bilateral defect had only 46% of patients with clear speech, whereas not clear speech was also seen in half of them. Right side fared slightly better as far as clarity of the speech was concerned. In isolated cleft palate, whenever incomplete palate was there, speech was better. That is about 57% of them had clear speech as compared to bilateral palate that is involving nasal cavity as well. So oral fistula rate in our patients was around 24%, but isolated cleft palate it was about 12% only. Cleft lip and palate, 50% had fistula, but that includes unrepaired alveolar clefts also. So second important parameter is maxillary growth. So these are various measurements which are seen in maxillary growth. So our orthodontic colleagues, they assessed maxillary growth by using these impressions, and it was seen that maxillary growth was affected across board in all the patients in all parameters. Early on during our experience, we analyzed some 30 of these patients, and although the patients may not be assessed or may not be symptomatic for hearing loss, but many of these patients had hearing loss and tympanic membrane abnormality. So one of the recommendations of that paper was that these patients should be put under audiological surveillance even when they are asymptomatic. These are some of our patients who were repaired for unilateral, bilateral defects. And it is important to photograph these patients in two views, frontal view as well as lateral view, because lateral view will reveal the maxillary growth retardation. So this one patient who underwent palatoplasty, so one can see that palate is repaired, palate is healed nicely. But then one of the famous cleft surgeon remarked that to assess success of palate repair, you have to listen, not look, as speech says it all. So we asked our speech therapy colleagues here to give us some piece of text which the patient should speak and which should assess all the components of speech, that all words which can cover all aspects of speech. So this patient was developed by speech therapy unit.
एक बार की बात है, अकबर बादशाह किसी गांव से होकर जा रहे थे। सर्दी के दिन थे। गांव के लोग आग जलाकर उसके चारों ओर बैठे बातें कर रहे थे। जब बादशाह अपने साथियों के साथ वहां पहुंचे तो एक ब्राह्मण कह रहा था कि मैं यमुना के पानी में रात भर खड़ा रह सकता हूँ। अकबर को इस बात पर विश्वास नहीं हुआ। उन्होंने ब्राह्मण से कहा कि यदि तुम सारी रात पानी में खड़े रहो तो मैं तुम्हें थैली भर मोहर।
But this is not the result of speech, the result of surgery only. This patient is speaking like that after more than 2 years of speech therapy. So to conclude, mid-face retrusion is a problem in cleft lip and palate patients. Visual deficiency may be a factor. Timing and technique of orthoplasty should be determined for each individual patient. But key to proper outcome is multidisciplinary management, which includes surgeons, speech therapists, and orodontal colleagues to achieve optimal goal of speech and magnification. Thank you.
Very nice presentation, sir. I just wanted to ask a question regarding submucous cleft palate. What is the general practice like?
For submucosal cleft palate is basically complete palate only. In the center it is attached by mucosa. So what we do is that we will convert it into a vial at the time. then mobilize them through as normal ballot repair.
I just want to make a comment. I don't know if it's working or not, but I think I'll be audible. Today morning, what a coincidence was that today morning in the class, we were doing the palatal surgeries. Said collectoplasty, VBAC, all that, and students had a lot of questions about what technique are we using PGI. I think your presentation would have made a lot of their doubts clear and how the outcomes are. Thank you so much for choosing this topic.
Thank you so much, sir, for your wonderful talk, and thank you, Dr. Nurain, Dr. Anuradha, and Dr. Maryada for your opinions.
Our next speaker is a stalwart in the field, Professor Ramadik, Professor Department of ENT. I would request sir to please join on the dais. I would request Professor Sanjay Munjal and Dr. Gyananjan Naik to chair the session.
Good evening, everyone, respected dignitaries, chairpersons, colleagues, and my dear friends. I'm Ramadik from the Department of ENT. I'll be speaking on auditory brainstem implants. Dr. Jaya and Dr. Roshan have already beautifully presented the cochlear implants, and they've shown results how well these children do if they are implanted early or implanted bilaterally. So now the issue is what happens if the child doesn't have a cochlea or he doesn't have an auditory nerve. That is where we come in, and that is the auditory brainstem implant. So just a basic overview, it is a surgically implanted electronic device that provides a sensation of sound to individuals with profound hearing loss caused by a missing or non-functioning auditory nerve or cochlea. Unlike a cochlear implant, which stimulates the auditory nerve, the ABI bypasses the damaged peripheral auditory system to directly stimulate the cochlear nucleus in the brainstem, which is the brain's first relay station for sound processing. So basically in the ABI, we are targeting the cochlear nucleus. So what are the parts of an ABI? It consists of a receiver stimulator assembly, just very similar to the cochlear implant. Then it has an electrode paddle, which replaces the electrodes of the cochlear implant, but it's like in a shape of a paddle, that's why it's called a paddle. And then we have the external sound processor, which picks up the sound from the environment. This is a picture from one of our cases. The white dots are the 7th nerve and the 9th and 10th nerve. This was a case which was done for absence of the 8th nerve or the cochlear nerve. So you can see that we have the 7th nerve, and then the 8th nerve is missing, and then we have the 9th and the 10th nerve complex. So what are the indications for an auditory brainstem implant? When do we go ahead, decide not to do a cochlear implant and go ahead with the auditory brainstem implant? It's used in NF2 patients. Complete cochlear ossification. So if a patient has meningitis, there are high chances that hearing can get knocked off and the cochlea starts to ossify. Now once the cochlea is ossified, there is no space to put the cochlear implant. So that is an indication for an ABI. If there is a skull-based trauma and the nerve gets avulsed, that is the cochlear nerve gets avulsed, that's another indication. Pediatric patients with cochlear anomalies, that is they are born without the cochlea or without the nerve. And congenital cochlear nerve aplasia or hypoplasia, that is either the nerve is absent or it is so thin that it cannot carry the signal onward to the brain. So normal nerve, we know the normal cochlear nerve is 1.1 to 1.4 millimeter in dimensions. Aplasia would mean complete absence of the nerve. Hypoplasia would mean that the nerve is anywhere between 0.2 to 0.6 millimeter or smaller than the diameter of the facial nerve. So that is how they see it on the MRI. They compare it with the diameter of the facial nerve. If it is smaller, then that means it's a cochlear nerve hypoplasia. So what is the decision-making matrix we follow? Let's say it is a vestibular schwannoma which has been resected and the nerve is damaged or partially resected. We assess the auditory nerve function, that is where our electrophysiology team from the audiology department comes in. If we find a functional auditory nerve, then the patient is given a cochlear implant. If there is no functional auditory nerve or we have no auditory nerve responses, then we do an auditory brainstem implant. The same pattern is followed for aplasia or hypoplasia of the auditory nerve. So like I said, the decision of the CI versus ABI is heavily based on electrophysiological testing. We have specialized testing at our department, which is the TTEABR and the ANTS system, which helps us make objective decisions whether we need to do a cochlear implant or whether we need to do an auditory brainstem implant. So once again, just a brief overview, the ABI electrode array is an electrode paddle that is placed directly on the cochlear nucleus of the brainstem. So the game here is finding the cochlear nucleus and placing this paddle on top of the cochlear nucleus. Just a brief overview, where is it located, what is it? So location is at the pontomedullary junction of the dorsolateral brainstem. It has two parts. So basically the cochlear nucleus is divided into two, the ventral and the dorsal. So what are the functions of the cochlear nucleus? It has the initial auditory processing center, non-auditory sensory information with auditory processes. And it's the primary target for electrode placement in an ABI. So which of these two nuclei are we targeting? The ventral cochlear nucleus is situated on the lateral surface of the inferior cerebral peduncle. And the dorsal nucleus is positioned in the upper part of the floor of the lateral recess, where it forms a prominence on the posterior surface of the inferior cerebral peduncle. So when we target it for an ABI, it is the ventral cochlear nucleus we are going to target. These are the practical boundaries for ABI, just for the surgeons here. Lateral is the foramen of Lushka, medial is the sulcus limitans, superior is the dorsal cochlear nucleus, inferior is the root entry zone of the cochlear nerve, anterior is the middle cerebral peduncle, and posterior is the inferior cerebral peduncle. So it is the red area we are going to target, the ventral cochlear nucleus, not the dorsal cochlear nucleus. Going to be showing a brief clip of one of our patients which we did recently. So we do these surgeries with the help of a neurosurgeon. It is a full team. So we can see the 7th nerve. The 8th nerve was missing in this case. And then we can see the 9th and 10th nerve complex. So after the arachnoid is opened, we find the Solomon's vein or other markers like the flocculus, and it is in that area that we push in the electrode paddle. So again, like I said, we are targeting the ventral cochlear nucleus. And once that is done, detailed electrophysiological testing is mandatory, because once this area is closed, we cannot go ahead and change the position of the electrode pedal. It takes a good 2 to 3 hours just for the electrophysiological testing done by the our department. This is some few pictures from the first auditory brainstem implant workshop we held at PGI in January 2025. Thank you.
Thank you, sir, for your introduction to the auditory brainstem implant. I would also like to reiterate the importance of reading a good radiology when we are managing these cases, because a poor cochlear nerve, a thin nerve, or a poor having absent cochlear aperture, even a cochlear aplasia with a dilated vestibule, they can be easily be missed. These patients can be inadvertently be put a cochlear implant if we are not very aware of the radiology. So that is also a very important aspect of our workup. And thank you so much.
So that is actually very important. We do get a lot of cases who have been implanted outside with a cochlear implant, whereas the indication would have been a auditory brainstem implant. All these patients become non-users and they have to be eventually explanted, and it's a lot of financial burden because the ABI is even more expensive than a cochlear implant. So they get implanted with a cochlear implant, then we explant it, and then the patient goes in for the ABI. I would also like to say that our department here at PGI Chandigarh is one of the few centers in India doing ABI, and one of the handful of centers in the world that does this surgery.
I would like to just, for the benefit of our students and some of our ex-students here, would like to, tell that, of course, this is a long surgery. Not only the cost is involved, but the amount of rehabilitation which goes into the ABI is much, longer period as compared to the, and the results, they start coming after a very long time when you compare it with the, cochlear implantation. So we have to be, as Dr. Gyan also said, that we have to be sure that the anatomy has, the radiological investigations have to be, perfect to see whether that particular child or recipient would be getting benefit with the CI or not. So the electrophysiology, as Dr. Vic already has emphasized, that good electrophysiological testing before before deciding whether to go for CI or ABI is mandatory, because when there is no response on the DT-ABR or the ANTS, then those are the candidates for ABI. So should not be just jumping for ABI, but first we have to be very sure that that particular child will not be getting benefit with the CI, then only we should go for ABI.
Yes, actually that's absolutely correct. Counseling in these cases is even more than a cochlear implant. Like Dr. Jaya had showed a bilateral cochlear implant. The child can start speaking beautifully in a couple of months. That is how beautiful the cochlear implants are. But with ABI, this is not the case. It would probably take us a year or two of rehabilitation just for the child to even have an understanding of the directionality of speech. So the time taken for rehabilitation runs into years as compared to a cochlear implant. Thank you.
Thank you so much, sir, for your wonderful talk. Thank you, sir, for chairing this session. I would like to.
Now I would like to invite Dr. Jayanti Bakshi and Dr. Professor Satyavati ma'am to please facilitate our speakers. Professor J.K. Mahajan. Professor Roshan Verma sir. Professor Ramandeep Vic. Now I would like to invite our chairpersons, and ma'am, please also facilitate them. Professor Sandeep Bansal. Dr. Gyan Ranjan. Dr. Dharamveer. Dr. Sanjay Munjal. Dr. Anuradha Sharma. And Dr. Nureen Alam. Dr. Maryada Sharma. For the final talk of the day, Dr. Aninda Datti Banik, Senior Manager, Clinical Asia Pacific and Research India. I would like to invite you on stage. Advanced Bionics. To chair this session, I would like to invite Professor Anurag Snehi Ramawat and Dr. N. Bhanumati.
Good afternoon, everyone, and good evening, I guess. First of all, thank you, organizing team and Madam HOD for inviting us to give this talk and share. Thank you. Today is the first time I actually reached the airport way early for a domestic flight and was delayed by three hours. Sorry for that. Just a second, let me just get this right. So I'm just giving this little small time to talk about probably the entire theme, which was actually a nice theme, Azadi from Deafness. And I think every one of us sitting out here, professionals, whether that be a surgeon, audiologist, or anyone from the medical field, we are all looking forward to kind of remove the disability and probably look at it from more Azadi point of view as well. So I guess today's talk, I'm just going to take you through a little journey about something which is there in cochlear implants, some things you may know it, some of them you don't, something new and something of the future. Because it's always not about loss of hearing, what it really results is a loss of communication. So just think about from that point of view. Everyone sitting out here, somewhere or other we need technology. We need technology to overcome these kind of issues in life and then create a feeling of azadi and giving them real freedom of their disability and do better in their life. And that's where cochlear implants also come in terms of the hearing perspective. So I'm not going to go too technical today, but I'm just going to give you a glimpse of what's there now and what's there in the future in three different aspects, because this is what you're going to be actually practicing when a recipient comes in. So a lot of you all know about MRIs, and that also is a hindrance. It creates an hindrance. Again, you need to create a feeling of azadi for the cochlear implantees when it comes to MRIs as well, because even for a normal hearing individual, always getting an MRI done is not right. It's not always the perfect way of doing it. 1 in every 5, that's about close to 15% need MRIs, and that also includes cochlear implantees. But what happens in a cochlear implantee is there is a lot of issues when it comes to doing MRI with an implant and a magnet inside, so that they could face a lot of pain. They could have hindrance of there is a surgery to remove the magnet, then they're off hearing for at least a month and 2 surgeries. That's again, it's hassle, and they're not hearing. So how is it, what is where technology comes in? And that's how technology like a 3D magnet, which is a 3-dimensional magnet, which is completely different in terms of what the cochlear implant industry has seen, and to acknowledge that, you even won the Best Breakthrough Award in 2019. A small little magnet, which is like the size of a 50 paisa coin or even smaller, that won the Best Medical Device Award in the entire world because of innovation where a child or an adult with a cochlear implant could just walk into their MRI room, get the MRI done, no need of a pressure bandage. Even if it is a bilateral implant, there's no issue of keeping your head still for like 10-15 minutes, which is a minimum requirement of an MRI, and then just come out and then wear the processor and go back home again. So that's where this kind of a magnet comes into place, and that's possible with a 3D magnet in the Ultra 3D. So it's a different type of magnet altogether, which rotates in all directions, as you can see. Just the x-axis, y-axis, I think everybody has studied geometry out here. So z-axis, which is basically a little bit of a tilt of the head. I guess you and I, you are sitting in the entire afternoon, I'm sure you're gonna move your head at least once in every second, every minute. So imagine a recipient sitting in an MRI room, how difficult it would be, even if you want to do an MRI of the leg. So that's where this magnet comes into place. So it's again giving them the freedom to hear all the time and not get restricted in one of the most needy time. And it's always a dreaded time where the surgeon, audiologist, rehabilitation gets a call that they need to do an MRI, and that's when people start to look at asterisks that you can't really do that, and there are other ways to probably try and get that done. So that's one aspect of it. I guess a lot of you all are surgeons, ENT surgeons and audiologists in the audience. So year on year we are talking about hearing preservation, but I would talk about something called structure preservation because we know how delicate the internal part of the cochlea is. And having said that, maybe manufacturers make the best electrodes, and every year, every few years, we try to keep getting better and better electrodes to make it atraumatic. But still, it is a known fact, at least 20 to 30% or more, there is some gradation of trauma when the electrode is inserted, even with the best of the hands and the best of the atraumatic electrodes. And that's where we need to think about something about a monitoring system so that it kind of guides. I think there's a big paradigm change in the cochlear implant candidacy. I believe a lot of students would still say, or a lot of people will think it's only severe to profound, but no. You see this green little shadow out here, that is a good residual hearing. That means people can also hear, but maybe they're not able to discriminate. These are all patients who are using hearing aids day in and out. So these become your candidacy for today's cochlear implant as well. But having said that, it's also now a responsibility in the OR that we preserve this during an electrode insertion. And that's where the new generation technology comes in. I guess you all must be doing a lot of electrocochleography and other objective measure tests. So this is also one of the tests added into something, a system called AIM system, which is an active insertion monitoring system. It does real-time electrocochleography. Basically, it records cochlear microphonics. I guess many of you are aware of what is cochlear microphonics. And it actually tells you about cochlear health. Cochlear health is a term where you're looking at the healthiness of the internal areas of the cochlea and how they are functioning even before or even after cochlear implants. Remember that electrode of a cochlear implant is a foreign body. What it does inside the cochlea, nobody knows. The industry is only hardly 35 to 40 years old. So, but we know that trauma can create a lot of issues in the future. So how do we tackle it from ground zero? So that's where something like a lot of surgeons know about facial nerve monitoring. So this is kind of a monitoring to monitor the electrode insertion and to see there is very less or no trauma inside the cochlea, especially if we're looking at translocations of the basilar membrane. And not just that, talk about azadi and talk about freedom. What about a freedom of or a sigh of relief that on the OT table, the cochlear implantee is unconscious, sedated, but on the OT table you put an electrode insertion, but you do an audiogram, automated, just like how you do an ASSR, you do an ECOG based audiogram, as you can see out here on my lower part of the screen, and then I think everybody is relieved that what was a hearing threshold before the surgery, has that been achieved after the surgery or not? That gives you an understanding of hearing preservation, but ultimately this is structural preservation. So that is an ECOG based system where you can do it active insertion monitoring during the electrode insertion. And I guess there are a lot of, I'm not going into details, this will leave it for some seminars that we'll do in the institute, but there are a lot of studies to show that when you use real-time electrocochleography, you can avoid a lot of scalar translocations, and that basically is giving you better structural preservation. Having said that, I told you I'll give you a little glimpse of the future. Many times you'll know about neural regeneration. I think there's a major project called the Rin Therapeutics. Now what is happening is, if you look at what is data, it's just 1% which is probably genetically linked at the moment. And if you look at severe to profound category or acquired losses, they capture the majority of an issue, especially in adults we are looking at. So 99% of the adults are actually affected by that. The next two slides is something, and a couple of slides on my presentations are confidential. So I request not to take photographs for those because some of these people who have given us the slide have requested that until the next paper publication. So this is a glimpse which I'm doing. So majority are acquired now, but there are therapeutics, and you all know about regenerations. So the AIM system, which I was talking about, the electrocochleography, that is being used during these therapeutics, and it has been given to patients, and the monitoring has been done of the cochlear health. How is the cochlear health getting better? Is there a generation of the ECAPs? When a generation of the ECAPs is happening at even lower threshold levels, that means it's performing better. So that's the kind of correlation they were looking. So that's how AIM, which is already in the cochlear implantee, and these are cochlear implanted patients, they have been given this kind of therapy, and then the monitoring has been taken care. So that's where this project has been undertaken in the last couple of years, and I guess this is in Europe, and there's already initial publications which has come out of it. Positive results are there, but yes, we are still a long way through the journey. But yes, there is. This is the future, probably where you'll see some kind of hope coming in. This was not genetically linked, but yeah, yes, we're trying to get there. So all of this is possible because I guess it is always about giving technology to the recipients. Whoever was implanted 25 years back then should be able to use today's technology processors. So that's where this entire timeline of the internal chip, as you can see on the screen, is there. And today we are looking at titanium implants, looking at 3D magnets, which gives them freedom to get into the MRI and do it. And that also helps us with a lot of sound coding strategies. Come what may, today a cochlear implantee may be doing great, but they're far away from natural hearing, and that's where sound coding strategies come in. I guess we all study about it, but it's the implant which should be able to support it. 25 years back somebody's got implanted, but today's coding strategy, if it is not helpful for them, then it's not again a freedom for them. They have to re-implant. So that is not the case in this with advanced bionics. Same chip, it's going to keep taking coding strategies for the next 4-5 decades, so that it has that much of a space there. So I guess we were talking about spiral ganglion cells and how they function. And that's where these implants can even do something like 120 spectral channels or virtual channels. You can't really put physical channels there, but you can make it virtually and get better pitch perception, better speech perception, temporal resolution, I think, which is a very important aspect in coding strategy to understand speech, especially in noise. And that's where these implants can really fire at the fastest rate. A nerve can do even much more, and even dynamic range. I guess we all enjoy a good range of volume. It's end of the day, I've been traveling since morning, so my voice is a little low, but yet you're able to, so at least this idea is something you're able to take it up. This is not my usual voice though. So that was about a little bit of the implant and where technology is there in the future. So probably just to wake you all up also, I don't know if this audio comes out of this. Audio check. Okay, I'm going to skip that audio video. But it was a recipient who was basically wearing this cochlear implant processor, and I wanted you all to actually count the kind of environment she goes in an entire day. So we think maybe 4, 5, 6 different environments, but this lady had gone to about more than 22 different environments. That's how the brain adapts. I guess everybody's brain adapts here. Guys in a very quiet environment, so brain is at one level. When you move out after the lectures, we were congratulating a lot of professionals before this. The noise was different, so brain adapts. So why not make the cochlear implant feel confident, and that's in true sense in Azadi for them as well. So think about, why am I talking about all this? Including this particular auditorium, there's a little bit of an echo. Now, the funny part is, there was a joke on architects, because if architects actually made classrooms across the world with their ears, it would have been a better costing thing for children. I'm not even talking about cochlear implantees or hearing it recipients, I'm talking about normal users itself. So architects don't make it with their ears. So that's the architect joke. I asked an architect about it actually. But if you Google and listen to TEDx or TED Talks, Julian Treasures, he was talking about this as well, where they need to use their ears because there's a huge gap, and this is a factor. This is one of the UK study I'm quoting here. Even in a integrated inclusive education, there is a literacy gap, there is a language gap. I guess everybody knows about this. But the gap is as huge as 24%, and that was one of the documented studies. In a classroom where a cochlear implant and a hearing aid user is there, as compared to a normal hearing children. So now, how do we fill this gap? Room acoustics does not support them. Environment, there is noise. That decreases the signal to noise ratio. I'm speaking very softly, but this is a quiet room. There's another good, so you're able to hear me well and at least comprehend a little bit. But what if, again, no audio, so I'm going to skip this slide. But even with the slightest of a noise, it gets stressful. There's a lot of auditory fatigue. There is a lot of listening efforts. I guess at the end of the day, you guys are also auditory fatigued at the moment. So that's where artificial intelligence comes in. Processors today have a lot of AI which can adapt to different environments. So this particular processor called a novel CI, it's completely wireless, can connect to any kind of a devices, and it has AI which runs more than 200 different programs automatically, something what our brain wants to do every day and every hour. And again, making it universally and giving them the freedom of connecting to anything. A processor which can connect to your TV, your basic 2000 rupees phone, or a gadget of 500 also, and if it has Bluetooth, it will connect to it. So they enjoy what anybody of us would like to enjoy: music, watching TV, YouTube, anything which they want to do, the processor can directly connect to that. And without using any other apps, it just giving it some further help to achieve the theme of the day as well. Assistive listening devices. I guess everybody studies about this, but you must be studying about a lot of people still write FM systems in their exams. That's outdated. You talk about dynamic FMs. That's also outdated. So they come, things have become more digitized. So these are digital modulations. This is something called a Roger, which is an upgraded version of FM though, and that gives a huge benefit. I believe, I hear this data from north of India especially, 20 to 25% cases are malformations in cochlear implant. Now when you talk about malformations, my always thought process, or ANSD, or hypoplastic nerve, it's not about the electrode. Electrode, yes, but beyond the electrode comes signal to noise ratio. That is going to make the difference for these recipients. And if you want to make signal to noise ratios better, you need to use ALDs to be better. So something like a Roger, use it with your thin nerve cases, use it with your complex cases, you'll see a huge difference in their benefit itself. And that's well proven, and Advanced Bionics does a lot of clinical research studies. We've done 11 in the last 7 years. This was one of our studies, and then we've also tested in the real world environment, and that actually gives a lot of benefit to these kind of cases. Not to restrict any recipients, I think freedom should be there. You know, how often your parents, a lot of parents would, of CI users would be saying, I remove the processor before they go for a swim, or they can't play Holi, or you know, they want to play in the muck or something, they want to play adventure sports. You can't really remove the processor because they're scared. It's too late. So, or an accidental fall like this. So, what will happen to this processor? That's where something like this and a battery, which itself is waterproof. It's actually waterproof. We were the first to come up with a battery which is waterproof, a case which is not going to break, so you can really be doing adventure sports, and a microphone which does not have a cover, but it is actually waterproof. It has an hydrophobic membrane. So that's where, again, a freedom to live a lifestyle what they want to do. India is a unilateral market, cochlear implanting. All across the world, there are at least 70 to 60% users who are unilateral cochlear implant users. So the other years is not there. So it's like this way. So again, it's not a freedom for hearing for them. And that's where bilateral, bimodal, or even pseudo-bimodal, which is cross-in cochlear implant comes in. So these are technologies which, as a professional, you can offer it to a lot of recipients, and in true sense give them better and better hearing on day to day. And I guess audiologically we know there's a lot of benefit when you use 2 ears. So it could be a matched hearing aid, or it could be a cross-in cochlear implants there. Coming to my last segment, again, we're talking about freedom. Telehealth is, I think, a big freedom, right? How many of you all have called a doctor and said, you know, can you help me over the phone itself? That itself is teleconsultation. A lot of troubleshooting of cochlear implant happens on the phone. We used to use third-party apps. So telehealth, teleaudiology, telerehabilitation, that is something we've been practicing since a decade or more. So there's a lot of investment by Advanced Bionics, and you can see on the screen out here, these are apps which can be used before cochlear implants, after cochlear implants, and adults, or even for complex case disorders, you can start using them. And this is all digitized. So it's an entire model where apps, website, links, and a lot of things we even put use. Many of you all who are looking therapeutics or CI and start using this in your clinics as well. So something like a remote programming, they must be, even they are in a different country. From here you can take over just by an app, and you do live programming as if they're sitting in front of you in their own environment itself. This is a very interesting app, I guess. I mean, you guys can in fact download it right now, and all your hearing aid users as well, they can start putting in their goals, and they understand about expectation, they understand about cochlear implant journey, and they get a better guidance as well. Sometimes they are a little lost, and this is an app which actually helps them. This is the My Hearing Guide app, again a part of the telehealth discussion. And to this is the first step, ABS taken, self-assessment app. Very often after 2-3 years, do we really know how our recipients are doing? We actually don't. They don't come back to the clinics, they don't come back to therapy, they are on their own. If you ask them kaisa kar raha hai, acha kar raha hai. But kitna acha hota hai? Do you have a percentage of this? So this is an app. Of course, this first app is in English, the next one's going to have Hindi as well, and digits 1 to 100, I guess everybody knows that much in English. Phonemes, if you want to go a little higher word and the sentence level, all of these tests can be just an app, and you can connect it to the processor, and they get to test it, and the results can be shared with a surgeon and audiologist, and then okay, something is right or wrong. There's a graph going up over 3 months, 6 months, 12 months, whatever, and that's where you can get into remote programming or call them back to the center. It is basically making things better in the cochlear implant industry, so that outcomes at the end of it are better. It's not only about just doing an implant, it's about how you are really making things better for their users. And now a little glimpse in the future. Again, a request, no photographs on this. So I spoke to you all about lateral wall electrodes, different type of electrode called mid-scalar, which is sitting right in the middle of the scalar tip line, both for atraumatic. What about mixing them together? So it's a little glimpse about what's going to be the future of something called self-curling electrode technology using polymers and heat of the body. So here's a little video. See this? Yeah. So as you can see, this is the blue one is kind of a polymer inside the electrode, and after the insertion, so it takes the root of a lateral wall. But then we know that if you are going to go a little bit closer to the modulus, not too close to the modulus, AB and certain manufacturers do not believe of going very close to the modulus because it can do more harm than good. So you got to be closer to the modulus, but not too close, but not even at the lateral wall. But over the period of few hours, as you can see, this has taken a position of the lateral wall, the outer area of the cochlea. But as this gets heated to the body temperature, see what's happening to the electrode. This is curling on by itself, and as you can see, it starts to go a little deeper and more deeper and takes a position pretty close to the modulus, but not trying to insertion. If you're trying to go very close to the modulus, it can translocate, and that's a fact. 34% of translocation happens in perimodulus, so rather go towards it, but later on. So this was a video which is a time glimpse video over 3 hours transition of the body heat, and that's where it takes the position. So this is the future of electrodes which will be coming through. And currently we have this research software, and very soon probably in the commercial way. I guess you'll know about AI and shaping of the cochlea, but what about today's generation softwares do not estimate where your basilar membrane is. That becomes very difficult to understand, and sometimes as a surgeon you might want to predict, okay, after 4 millimeters of insertion I'm going to change my angle. How do you do that? That's where softwares like these, research softwares, which is Simago, which takes a pre-CD and we run the analysis, and then you take post-op CT and you're able to find out not just retrospective data, but also sometimes you can also predict cochlear implantation about changing angle, working with AIM, and then making it more atraumatic. So that's where Simago analysis software, 3D modeling works in. And I think that's kind of the end of my presentation. World is getting better and better at AI. Many of you all would have heard about Spear technology, which is a hearing aid technology, but the chip itself can do deep neural networks. Familiar with deep neural networks? Have you heard about it? Deep neural networks. Yeah. So deep neural network is in hearing aid. You can see on the screen. It's based on 22 million samples, and that's the kind of possibility. And the AI keeps learning. There's nothing in the industry which has come till now in the hearing aid area, in the listening area. But AB owns part of Sennheiser as well, and obviously R&D wise along with Phonak. And this is going to make its way to cochlear implant in the future. So a very deep neural network in CI, and that's altogether. I think innovation technology. I guess it's a lot of in the manufacturing. Of course, there are engineers, there are audiologists, there are surgeons who are day in and out talking about technology, working on it, and that's how today we're able to give it to a recipient. Otherwise, without this, I think the CI industry wouldn't have been there. So it's, to sum it up, I usually like to use this quote because it's not just we hear from ears. You give the brain a lot of these information, and the brain then beautifully shapes it up. And that I guess is going to be the way forward for cochlear implanters as well. So I guess they can live a life without limitation, and I guess that is the true sense of our life.
Thank you, Dr. Ban. It was an interesting talk. So how the biotechnologists and the biomedical engineers are working towards the precision. When you talk about the azadi, I would say azadi would be for a child when they can play around. especially the contact sports. The advanced bionics, I think, has been working for a lot of, they can play in water as well, but when it comes to playing the contact sports, I think still there is some limitation.
Yeah, I guess so. But these implants internally can take up till I shouldn't quote the number, but it's 13 joules, which is enough to break bones. It won't break the implant, but yes, as per FDA rules, there is some limitation, and we are always going to be conservative about contact sports. There is always they're going to be recommending wear headbands just for an additional level of protections to the implant, of course. That limitation is going to be there, but yes, under the testing, it has officially given 6 joules by FDA. 6 joules is like 100 grams weight from 6 meters, which is enough to shatter the bone, but it won't hit the implant. But yes, for safety is always.
And the interesting part is the neuroprotective, function which the companies are looking at, so that the residual hair cells can be protected.
Thank you, Dr. Ananda. It's not new to me at all for sitting and listening to you. It was wonderful, in fact, overwhelming to see the technological advancements that we have been through for the last 2 decades. So there is no reason behind to say audiologists and habilitationists work separately, because with these advancements, I can say easily we have moved from can they hear to can they think and read. So we are no more looking into the hearing aspect, rather we are more into the cognition and language development, and we are no more into articulation drills. It's way high beyond that. And we measure our outcomes beyond the auditory, the audiogram. We are not just seeing the aided audiogram, measuring the outcomes based on many speech perception tools, and you have actually briefed it very well in most of your slides with the technology. We can audit even the outcomes based on all this. So wonderful presentation as always. Thank you so much, and I'm sure they have a lot to take home today from your presentation. And we are looking forward to use the tools as well.
Thank you so much. Thank you for the opportunity.
Thank you.
Thank you so much, Dr. Bhan, for sharing your expertise, and thank you so much, Dr. Anurag and Dr. N. Bhanumati. I would request Jayamanti ma'am to please felicitate our speaker and also our chairperson, Dr. Ananda Banik. I would also like MS sir to please join. Dr. Anurag. Dr. N. Bhanumati.
Thank you, ma'am. Thank you, sir. Now it is now the time to recognize excellence and dedication. We'll now present appreciation awards to our PGI alumni who have been working through decades in our field. I will request Sanjeev Kumar sir, Dharamveer sir, Jayamanti Bakshi ma'am, and our medical superintendent Vipin Kaushal sir to come in the front of the stage. I would request Professor Sanjay Munjal sir to come in front for the appreciation award.
घर में
Yes, sir.
Dr. Ravi Kapoor. Mrs. Gurvinderjeet Kaur. Mr. Sanjeev Kumar. Dr. Pooja Vash. Dr. Nidhi Bhatnagar ma'am. On account of World Disability Day, there have been many NGOs working tirelessly for eradicating disabilities and everything. We are now continuing with our appreciation. We would now like to honor the NGOs for their relentless contributions to differently able communities. Their selfless service is what makes Azadi from Deafness a reality for many people. I would request Dharamveer sir to felicitate Sri Krishan Kumar Chopra for Honorary General Secretary from HW Society Panchkula. I would request Sri Ajay Datta sir to come in front of the stage. Shri Shiv Dular Singh, retired IAS officer from Punjab Red Cross Society. There are many volunteers from the Red Cross Society here. I would request everyone to come in front of the stage for the photography. Ms. Akashdeep Kaur from the Niti Aayog Paramedical Council. I invite Dr. Inderpreet Kaur, the medical officer. Dr. Amita, assistant professor from the Department of Music Vocal, PGCG Sector 11.
ये डॉक्टर साहब डिसेबल्ड को डॉक्टरेट करवाएं।
Dr. Amita has been helping these differently able people to complete their PhD program. Mr. Amit Kumar, SDO, UHB-VVN.
And when he left, please, I don't know, any NGO, other NGO has come up.
Each 7 popular implants as donation from Uttar Haryana Busy Nigam. Mr. Amit Kumar is receiving there.
As we approach the end of this memorable event, I invite Dr. Satyavati Mohindra, Unit Head 2, Professor, Department of Otolaryngology, to propose the vote of thanks for this event. Ma'am, please come to the dais.
Good evening, everybody. Respected Chief Guest, Professor Sanjay Jain sir, Guest of Honor, Shri A.K. Datta, my seniors, colleagues, and the speech and hearing team. As we come to the close of this impactful afternoon, I am asked with proposing the vote of thanks. But today, thanks feels like a small word for the magnitude of what we are trying to achieve. That is Azadi from deafness. First, my deepest gratitude to our Chief Guest, Professor Sanjay Jain, Dean Research. Sir, your presence is a strong signal that PGI MER's academic machinery is fully behind the cause of disability rehabilitation. Thank you for your leadership. I extend heartfelt thanks to Shri A.K. Datta, our guest of honor, for standing with us in this noble cause. I must acknowledge the captain of our ship, Professor Jaimanti Bakshi ma'am. Your vision has turned this department into a sanctuary where surgical precision meets human compassion. Now I must turn to our distinguished speakers who have so brilliantly illuminated the path today. Professor Roshan Verma, we are grateful for your insights. When you operate, you don't just repair an organ, you restore a connection to the world. Thank you for showing us that technology can indeed touch the soul. Professor J.K. Mahajan, it was an honor to have the HOD of pediatric surgery with us. Sir, in my own work with pediatric otolaryngology, I see daily that a child's silence is the heaviest burden for a family. Your presence reminds us that treating a child requires a village. Collaboration between ENT and pediatric surgery is the key to healing our youngest and most vulnerable patients. Professor Ramandeep Singh Vail, thank you for your talk. We know you as a great teacher and surgeon par excellence. Your reputation in stepedotomy and cooperation technologies precedes you. You represent the cutting edge of our field, the surgical hands that physically remove the barriers of deafness. However, a surgeon's knife can only do so much. The rest is done by the heart. This brings me to the speech and hearing unit and our speaker, Dr. Aninda Dutipani. To the audiologists, speech therapists, and the alumni we honor today, you are the soul of this department. We surgeons repair the hardware of a computer, but you are the ones who operate the software. You teach a child that the sound they hear is ma. You teach a stroke survivor that they can speak again. Without your patience, your empathy, and your tiredness therapy, our surgeries would be incomplete. Finally, to the NGOs present here, thank you for being the bridge between our hospital and society. Let us leave this hall with a promise. As long as we have the skill to operate, the technology to hear, and the heart to heal, we will fight for this Azadi. Thank you and Jai Hind.
Thank you so much, ma'am. Ladies and gentlemen, we request you all to kindly seat up for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे सब जल गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you everyone for being the part of this event. And now I would request everyone to please join for high tea downstairs.
कर
मतलब बंद कर दो।